A very good morning, all of you. So today's live session will focus on the following case-based question, right? And also I have some homework questions for you. So here we go. So as you can see, a patient reports to a clinic, a middle-aged patient reports to a clinic with a chief complaint of bleeding gums, spaces between teeth, and loose teeth. So consider these as your keywords: bleeding gums, spaces, and loose teeth. So, which is obviously conclusive that a patient has periodontitis. But let's not jump into conclusions. On further clinical examination, you notice that the clinical attachment loss is around 5 mm. Disease severity may be described as mild, moderate, severe, slight. So, based on the chief complaints, based on the clinical attachment loss, what would be the categorization of the disease, the periodontal disease the patient is speaking? So it's a periodontal disease, even though I haven't mentioned the term periodontal. So I'm telling you now, it's a periodontal disease. So how do you categorize it? Based on the given keywords. So is it mild, moderate, severe, or slight? Yeah, we have a classification of division of severity of periodontal disease based on clinical attachment loss. 1 to 2 mm of clinical attachment loss is mild or slight. 3 to 4 is categorized as moderate. 5 mm or more than 5 is categorized as severe. We're talking about clinical attachment loss. I'm not just mentioning pocket depth. We're talking about clinical attachment loss. Okay. So I hope it's clear. I see most of you choosing option B, but we're talking about clinical attachment loss, which is option C. So 5 mm. So do make a note of these points. 1 to 2 mm of clinical attachment loss is categorized as slight or mild. 3 to 4 is categorized as moderate. 5 mm or more clinical attachment loss is categorized as severe. Okay, I hope it's clear. Now, let's move on to the next question. Clinical attachment loss is measured from what are the landmarks? From gingival margin to the bottom or base of the pocket, from incisal edge of the tooth or occlusal surface or occlusal aspect to the bottom of the pocket, or from DEJ to bottom of the pocket or base of the pocket, none of the above. So which one do you think aptly fits into the description of clinical attachment loss or clinical attachment level? So it is measured from which of the following? Okay, yeah. So that's the speciality and importance of clinical attachment clause, clinical attachment level. So it is rather a standardized means of assessing the progression of periodontal disease because we are using a stable landmark, which is CEJ, right? So from CEJ to base of the pocket. So none is right answer. Yeah, good, very good. Now let's move on to the next question. Polymorphism in which of the following genes is associated with severe chronic periodontitis? So consider this very, very important. It's mentioned in one of the risk factors as well. So polymorphism in which of the following genes is associated with severe chronic periodontitis? Genes encoding IL-6, genes encoding TNF, IL-1, none of the above. So which one do you think is more appropriate answer? I know it's a difficult question, but it's okay. You can make notes, revise, refer, and then get more clarity on this concept. Good. So, as some of you are mentioning, it is genes encoding for interleukin 1, which leads to excess formation of IL-1 beta, which increases the risk of severe chronic generalized periodontitis. Right? So, consider this very, very important. So chronic periodontitis in a severe form. So polymorphism in which of the following genes is associated with severe chronic periodontitis? Genes encoding for IL-1. Okay, so consider this very, very important. What is polymorphism? We'll discuss that a bit later. You're planning an intraoral examination, a radiographic survey. further radiographic survey, which should include a minimum of how many radiographs? In fact, this question was asked in the latest entrance as well, 2020. So you're planning intraoral radiographic survey, which should include a minimum of how many radiographs? And you have the following options: 10 periapical films and 4 posterior bite wings, 12 and 6 respectively, 14 and 8 respectively, 14 and 4 respectively. Look into the question again. It says intraoral radiographic survey and the keyword minimum. So which one do you think is more appropriate answer? Yeah, I'll show you a radiographic image. I mean, the collection of radiographs, which are part and parcel of intraoral radiographic survey. So can you just count the number of bite wings and periapical films in this particular image? So you can see we have 4 bite wings and we have, if we count, 17 periapical films, isn't it? So the question is, but by the way, you don't have 17 here in the options. So which one would you choose? We're planning intraoral radiographic survey, which should include a minimum of how many periapical films and bite wings? Yeah, what you find in the image, 17 and 4 respectively. Very good. So 14 and 4 as per Karunza. So a minimum of 14 periapical films and 4 bite wings, right? In order to have this intraoral radiographic survey, consider this very, very important. And in the entrance, they've given you 17.4 as option. You can obviously go for it because the image is from Karunza, which I have displayed now. So final question, which of the following is most important in determining the prognosis of tooth? Which parameter? Bleeding on probing, pocket depth, clinical attachment level, mobility. So based on a discussion, which one do you think is more appropriate? Or which one do you think is more important or more accurate in determining the prognosis of a tooth? Good. So pocket depth is something which we measure from the gingival margin to the base of the pocket. So bleeding and probing, it can be because of numerous factors. It doesn't necessarily indicate the severity of bleeding. I mean, the severity of infection. Clinical attachment loss is, by the way, mobility. There can be mobility even because of various other factors like accumulation of pus, trauma. So there can be various other factors as well. But clinical attachment loss, it gives us an idea on disease progression and severity because we are actually using a stable landmark to assess the amount of attachment loss, isn't it? So from CEJ, we're trying to assess the depth of the pocket, thereby reducing the attachment loss. In fact, we have a very interesting way of evaluating the attachment loss, and we discussed that in one of our previous discussions, study club discussions as well. So depending upon the level of gingival margin with respect to CEJ, we either add or we either subtract. I'm sure you know about that, right? So clinical attachment loss is considered to be a more reliable factor in assessing the prognosis of the tooth. So I hope it's clear. And if you have any questions, you can get back through me for any further clarification, right? So before I summarize all that we have discussed so far, I have the following questions for you. So we'll do one thing. Let me just summarize all the content and then we'll go into these questions and then you can get back through mail. So we've seen a patient coming to a clinic reporting certain chief complaints such as bleeding gums, spaces between teeth, loose teeth, or mobility, which clearly indicate that it's a case of periodontitis. By the way, does chronic periodontitis have, I mean, is it symptomatic? Does patient have pain? Okay, so we've come across this case on clinical examination. The clinical attachment loss, CAL, or clinical attachment level, is 5 mm. Loss is 5 mm. So depending on that, we can categorize this as a severe periodontitis, right? We have a classification. And as you mentioned, clinical attachment level is measured from CEJ to the base of the pocket and polymorphism in genes encoding for IL-1 leading to excess production of IL-1 beta increases the risk of developing or increases the severity of this periodontitis, right? So consider that very, very important. And if you're planning an intraoral radiographic survey, a minimum of 14 periapical films and 4 bite rings are necessary. In the image, which we can find in Karanza, you can see 17 periapical and 4. But the minimum criteria, as mentioned, is 14 and 4. And which of the following is most important determining the prognosis of tooth? Clinical attachment level. So level of attachment can be assessed, as you know. Consider that topic very, very important, right? And this is what I wanted to highlight in this specific live session. I hope it's informative. And I have the following questions for you, again, based on this clinical attachment level. The first question is shallow pockets attached at level of apical third of root. So we have two situations. Shallow pockets, which are attached at the level of apical third of the root. And the second scenario is deep pockets, which are attached at coronal third of the root. So in which of the following is the disease severe? So I'll repeat the question. Shallow pockets attached at level of apical third of root is one case. The second case is deep pockets, which are attached at coronal third of the root. So in which of the following the attachment loss is more or the disease progression is severe, right? So that's the first question. And the second question is, what is polymorphism? They say when there is more than one allele at the particular gene locus, and it should have a distribution frequency of at least 1%. But what is gene polymorphism? What does it indicate? The third question is, which probe is used for probing implants? Plastic probe, steel probe, wooden probe, any of them. So these are the three questions which I wanted to highlight. And see if you can find out by referring Karanza, and then you can get back through mail. I'll help you accordingly, right? And for your convenience, I'll type these questions and post them in the comment section so that you can make a note of them, right? So I hope it's clear. So I'll see you again tomorrow at 10:30 a.m. Indian Standard Time. So wish you all the best, love you all, and have a great day ahead. Take care.